All right, everybody. Aloha, everybody, and welcome to Facebook Live with Mel and Charlie. We have a special edition tonight. We are hosting a press conference. We talk about issues surrounding Kauai's decision to apply for a 14-day mandatory 14-day quarantine. We are going to discuss Dr. Dara O'Carroll's analysis as well as input from four of Kauai's doctors. Of course, we have Dr. Dara O'Carroll here. We have Dr. Janet Berman, who's our state district health officer, Dr. Kapono Chong Hansen, who's a physician here out on the West Side Community Health Center, and of course, retired physician and former CEO and executive of Wilcox Hospital and Kauai Medical Clinic. And of course, the man on the keyboard over there to the right, or wherever it is on your screen, Mr. Charles Iona. I'm Mel Raposo. We're gonna go right into, we got some of our media on. We are gonna turn this over to Dr. Evslin. Dr. Evslin, the floor is yours, my friend.
Thanks for having us, Mel and Charlie. It's a pleasure to be with you guys again. I'd like to start the official part of this by actually thanking Governor Ige and thanking our Mayor Derek Kawakami for requesting the opt-out and then for granting it. That was not an easy decision or request, I'm sure, and I think it was bold and courageous to do it. And I'd like to make it clear, as far as I understand, and I'm not on the mayor's team, but as far as I understand, this opting out was not his first choice, it was his second choice. That basically what the mayor had done is asked prior to the Safe Travels program back in early October and before then that there be a different system, that we have a short quarantine on Kauai with a second test. And then he made that request again, I think 2 weeks ago, as we began to see these kind of alarming numbers on Kauai. And that was turned down. And as I understand it, that left him with either staying in the Safe Travels program or opting out. And for the safety of Kauai's residents, for issues that we're going to discuss further on in this, he decided that the highest level of safety was to opt out. And I want to make one other point that's interesting is the CDC just last week started to discuss a new proposal, and they put out a paper basically, which isn't a formal recommendation, but it's a request for discussion. Basically, what they're saying is they no longer think for travel a 14-day quarantine is necessarily mandatory, that with proper testing you can do a shorter quarantine, and they talked about a 7-day quarantine and a second test before that 7-day quarantine is up. So the CDC is actually moving towards a formal recommendation that's very similar to what our mayor was offering in terms of safe opening. So I think that's important to know. As we listen to the state press conferences, we hear very interesting and kind of reassuring numbers. In the state press conferences, what I'm hearing is that our state new case numbers are about the same, that they aren't really going up, that the surveillance testing that they've been doing with thousands of people is not showing large numbers. In other words, not showing large numbers that are coming in infected and missed on the first test. The hospitalization rate is dropping, particularly since July, which all sounds positive. And economically, things look better. So that's a pretty rosy picture. And I think a very real question to anybody watching this was, what are you guys worried about? With those good numbers, what is to be concerned about? And essentially, we're going to cover some topics, and I'm just going to briefly go over them. But topic number one, very briefly, is just capacity, which everybody knows we're always worried about on the neighbor islands. We have such limited medical capacity. Not that we don't have surprisingly good healthcare systems for rural areas, but the capacity is limited. And the state capacity is limited in terms of us being the most remote landmass in the world. And if the neighbor islands began to overload Oahu, certainly would be problems. And along those lines, there was an open letter that was created early on in the Safe Travels program, actually before it started, that was expressing concern about the Safe Travels program and issues with capacity and the actual calculations they were doing. And essentially, that open letter was signed by over 100 doctors, over 200 RNs, and over 500 members of the community, this open letter expressing concern. So capacity is certainly something that's on all of our minds. The other thing that you're going to hear tonight is an analysis of the calculations as we understand them that the state made to attempt to guess or to predict how many people would come into the state infected but not detected by a single test. And that relies a lot on the prevalence of the, how much disease is in the people that are traveling, and then what is the problems with a single test picking these people up. And there's going to be two wonderful presentations. One is by Dr. O'Carroll, who was part of our panel, created a very high-tech presentation that's been well vetted around the state and the University of Washington. And the other presentation is actually going to be by Dr. Kapono Chung Hansen, and that presentation is actually looking at data from the data and a study from the University of Washington. They looked at the analysis that we have here in the state of the numbers, basically this analysis of the projection of what would come into the state, and they had grave concerns essentially about the formula that was used for the analysis, and then issues with a single pretest allowing to eliminate a quarantine system. And the final part that will be covered essentially, although it'll be covered all through this, is the numbers on Kauai, the numbers that worried our mayor and worried our district health officer and worried us on Kauai are kind of clean numbers. We had no cases on Kauai when we started. So everything we have here is kind of a clean number, and you'll see how we doubled basically the 40 days that we've been open. And even more alarming is that we've done case surveillance on Kauai, and it's giving us numbers that may be predictive of the state. They are actually quite worrisome of the number of people that are coming in infected and not detected. That's my part, and I am going to turn this over. I guess one final part is what a main concern that we have is if we don't shut down, at least temporarily, and get ourselves back under control, that we actually may go to a full shutdown, meaning closing schools and all of the implications that that has, which will also be further discussed. So the second part of this is Dr. Kapono Chung Hansen, and he is the medical director from the West Side, and he's going to give us a brief overview of what the University of Washington found as they looked at the data here in Hawaii and the formulas used. Thank you.
Gotta unmute Kapono.
Okay, got it. All right, aloha kako. My name is Kapono Chung Hansen. I'm the medical director for Ho'olalahui, Hawaii and Kauai Community Health Center. So that's the Native Hawaiian healthcare system and the only federally qualified health center on the island of Kauai. I wanted to run through relatively briefly kind of how I got involved in this work and some of the concerns that we have that led to this situation now, where we felt like it was valuable to have an opportunity like this to share information. So one of the things that happened early on in the pandemic on Kauai was that a group of the leaders of the largest medical providers on the island started meeting once a week with Dr. Berryman to share information about the pandemic, planning. A lot of it had to do with our limited resources, such as testing resources. And our community health center also got a grant to help improve access to testing. So that's kind of started all of these conversations that I became involved with. Around that time was when the state first started talking about the pre-travel test and reopening. And it first caught my attention that there was going to be a logistical issue with verifying the test results before boarding the plane, which is still an issue now here in November that we're seeing. So a group that Bill was a part of, the Kauai COVID discussion group, had already formulated a pretty comprehensive reopening plan with the help of Dr. Michael Schwartz and Dr. Carl Kayala, who are from the University of Washington. And they had a proposal that included two-step testing, quarantine, hotels, contact tracing. And so that's kind of like started the discussions there. If I can share a slide or share my screen and start there. Okay. Okay, so I think you guys can see a table now. And this is was the gist of our first work. So we were using this analytical model that our UW connections had helped us with. And we were looking at the days since the first test and how many infectious travelers would enter undetected, and then based on different prevalence levels. So if you look at day 0, that means there is no second test. So these are the numbers expected without any second test. And I'd like you to just take note of 1.5% up here at a prevalence of 1.5%. No second test, we'd expect 64 per 10,000 or 6 per 1,000. I just want you guys to keep in mind the 6 to 7 per 1,000 because that number is sort of coming up again and again as we look through data now. So at first we presented this to the state and they seemed more receptive to this idea. Later on, sort of less receptive, and there was some contentious discussion about prevalence and what the true prevalence should be estimated to be amongst travelers. So we did some research trying to look at where is the state getting their prevalence data from, and we found this table which looked at the top 10 states where travelers came from, and California had a nice number of 1%, which is an easy one to work with, and we tried to understand how the analysis was done. But the key part is that the prevalence used is called a case prevalence. So it was the total active cases over the total population of the state. And the important part there is that the case prevalence always underestimates the true total infection prevalence because not everybody who has COVID gets tested and diagnosed. They might not be very sick. They might not have access to testing. They might not want to have to quarantine because they have to work or care for somebody or many reasons, but it's always bigger. And HIPAM and other analyses have come up with a factor of 3 to 10. This group in Hawaii, HIPAM, I'm told, uses a factor of 7 to try to estimate what the true total infection prevalence is in a population. So Dr. Carl Kayala, he also helped to make another graphic. But before I move on to that, I just wanted to note that these prevalences are dynamic. They're increasing in general on the mainland. And right now, the most recent California is up to 1.5%, similar to that table that we talked about before. But the state doesn't really have a plan of how to respond to increasing prevalence other than like the mayor opting out. And I think that might be a factor, probably was a factor in his decision. So getting back to the case prevalence versus the true infection prevalence, Dr. Kayala made this iceberg graphic to demonstrate it. And you can kind of think of the ice above the water as being the detected cases, and below the water is all the cases that are not detected. And this actually is roughly the sort of 7-to-1 ratio that HIPAM uses. So essentially the state calculations as we understand them were that only a subpopulation of this iceberg above the water, about 30%, would travel because most of them are symptomatic or too sick to travel. But in reality, in the analysis, this whole part down here is a whole pool of potential travelers that could be pre-symptomatic or asymptomatic. And that was the source of a large underestimation. Other criticisms or other aspects of the analysis that Dr. Kayala came up or shared with us for that, the risk of infection during travel, which has also become a concern. You might have heard recently in the news that there was a traveler to New Zealand who infected, I believe it was 4 travelers and then 7 cases total after being positive on the flight. So after doing some adjustments for prevalence, Dr. Kayala came up with a number of 4 in 1,000 based on a 1% prevalence, maybe 9 in 1,000 based on a 2% prevalence. And if we're looking at that 1.5% again, we see that 6 or 7 per 1,000, which also matches what Alaska was seeing when they did their testing data. And Bill Evans was able to get that information for us too. So let's go back to that. So we were concerned about the reopening and the possible underestimation. And so we paid close attention once the reopening happened. And the first issue that came up to us was all these pre-travel positives, all these people that actually tested positive on their pre-travel tests and still arrived in Hawaii. And I think a lot of that credit comes to Dr. Berriman for bringing that issue to light. But now on Kauai, 20 to 25% of all our cases since October 15th were actually pre-travel test positive. And the news today, the governor shared that overall statewide, there are 300 cases of this where people tested positive before travel. So that's certainly concerning and much higher than what we had been hearing before then. The other aspect is it cannot be thought of as a good thing that these cases were found because they were not found in a systematic way. They were really found haphazardly. So sometimes reported through Department of Health, sometimes through the CDC, sometimes a person got tested for whatever reason and revealed that their pretest was positive. And unfortunately, the last two cases on Kauai in the county press release boarded the plane with pretest positive results, which is just hard to understand, but it's certainly a concern and certainly a risk that I don't think the state anticipated being as high as what we found it to be. So that was a concern. The next thing after the reopening was the stories that we're seeing about the surveillance study. And the way we understood it was the surveillance study was supposed to be a random sample of 10% of travelers to go get tested on day 4 after arrival. Now, when we started seeing some of the news stories, we were seeing much higher numbers than we expected. And then as we started looking closer, it was apparent that 90% or so of those tests were not really part of the study. They did not follow the study methodology. They were Mayor Kim's arrival tests. So those were not done 4 days apart. Some of them probably were done the same day. Sorry, I just heard some background noise. Okay, so 90% of the studies that were being portrayed in the media as a surveillance study, to me, really did not follow the surveillance study methodology. So at the press conference on the 19th, we were able to get some better numbers around the state about the numbers that actually were following the surveillance study methodology. And at that point in time, even though it was shared that Kauai had 0, we knew from our group discussions that Kauai had 5 cases, and the week before we'd had 2 cases as part of that surveillance study. When we combine our data with Oahu and Maui, we get 9 out of 1,339. So that's 7 per 1,000, and Kauai on its own was 15 per 1,000. So we're kind of back to that 6 to 7 per 1,000 number again as well. So now I think after some attention was put on the surveillance study, it's concluded. It seems like it was concluded early because it was reported it was supposed to run for 60 days. And I know there's been some discussion about the preliminary findings in that study. I just wanted to mention one thing from the preliminary findings suggesting that maybe residents are contracting COVID at a higher rate, and just share that on Kauai, we know that our returning residents sought post-arrival testing about 10 times at a 10 times higher rate than the visitors. So 20% of returning residents have accessed our county's post-arrival testing versus 2% of visitors. And the numbers for that are 5 out of 750. So once again, it's close to 7 out of 1,000, and that's amongst returning residents only being infectious in Hawaii. So based on some of this surveillance data, which we feel is misleading, if including all of Mayor Kim's arrival testing, but also based on other data regarding positivity rates and case counts, some of the data is reassuring. But when we look at it all, there are some reasons to be concerned, particularly on Kauai data, but also statewide. Lee Altenberg shared this graph with me. And what he did with the orange line is that the trend was going down before the reopening October 15th. And if that trend continued, you can see where we would be moving into December. And you see right around the end of October, the trend is kind of starting to go back up again. So this is sort of that downward trend flattening and starting to look like it's going to go back up. The other data, which is pretty easy to see on Kauai, is that certainly our case rate has gone up because we were close to 0. It starts around October 15th, and our positivity rate has also gone up. So overall, those are some of the concerns we've had with the Safe Travels Plan and some of the problems that we've encountered since the reopening. I really am starting to think about it. It looks like kind of like a fish pond. I understand it took a lot of work to make the whole plan for safe travels get up and happen. But at the same time, it looks like there are some pukas in the walls, and there are some places where we're getting leaks, and the system will not work if we allow those to happen. So our goal of sharing this data is to encourage our state leaders to be vigilant. Maka'ala. It's not that we all expect that our leaders will get everything right the first time, but when we start to see problems, we have to be ready to adapt to them. And we think that's what Mayor Kawakami has done. So I just want to leave everybody with the state motto, Uamau ke'eo ka'aina I kapono. The life of the land is perpetuated by righteousness, and I think that is what is going to lead us forward. So I want to pass the baton to my friend, Daryl Carroll, who's an emergency medicine trained physician, and he's going to present his brilliant work putting together a lot of data in a succinct way about concerns with reopening and travel risk.
Thanks, Bono. Just unshare your screen there, and then I'll share mine. All right. Really happy to be here. Thank you, Mel and Charlie, and everyone who's attending for letting me speak. It's really an honor to be here, and with everyone who's just kind of trying to talk really medicine and science. And that's really our whole goal here, is to talk medicine and science and present it in an objective way. So I'm going to present a paper that was peer reviewed that I wrote. It's been a accumulation of the last probably 2 to 3 weeks. It's entitled "How Hawaii Can Get Coronavirus Right in 12 Steps." I am an emergency board certified emergency physician and a disaster response physician, and also a writer. And so what I'm going to cover is some personal history in this pandemic, some brief history of prior coronaviruses, the 12 steps, and some economic consequences, and some closing comments. First, I'd like to open up with, this is a photo I took. I was honored to be the medical officer on the Alahulakai Omaleka voyage of Hikianalia up to our west coast of the United States. And I was the leg 4 medical officer from San Diego back to Honolulu. And this was, I think, somewhere around day 8 or day 9. They all kind of blend in a way, but it was the most beautiful sunset I'd ever seen. But how we got to this beautiful sunset was 2 days prior, we went through some really, really heavy storm fronts. It was around this time of year. Before those storm fronts came in, Kumu Bruce Blankenfeld, one of the PO captains, along with Nainoa Thompson, but Bruce was our captain that leg, and he was sitting at the top of the canoe and was just staring at the clouds intently for about 20 to 30 minutes. And I've paddled canoes and ba'as for all of my life, pretty much. But I've never been a deep sea voyager. And I turned to one of my colleagues and I said, hey, what's he doing? Like, is he seeing something? And the response was, it's never good when he looks at the clouds that long. And Janet Berryman has also, Dr. Berryman, who's also on this call, has likened it to, a slow moving tsunami. And so what we're seeing in the public health sector is either a slow moving tsunami, but I think the analogy is very powerful, that some pretty big storm clouds on the horizon. I mentioned I'm also a writer. I was hired by Netflix as a medical consultant for this docuseries that came out earlier this year in January called Pandemic: How to Prevent an Outbreak. I swear Netflix had no idea that this was going to happen. It just seemed timely, since these super flus or chances of everything happening were increasing as our world keeps increasing in its global nature. And my role was twofold. One was to research pandemics. This started all the way in probably late 2018, early 2019, and really talk to the production crew and tell them what storylines were plausible. And they wanted to do a bunch of shooting in our winter months, but they wanted to do it down in Brazil and Argentina. And I think one of the most useful things I told them was that, hey, look, there's no flu season at that time of year. So, they obviously changed a lot. My other role was a casting director. And so I had to talk to the who's of pandemics and interview them. I interviewed Dr. Fauci for about an hour. I can attest he's even more collegial on a personal phone call than on the news, if that's possible. But also Dr. Rick Bright, who was the hydroxychloroquine whistleblower. And now is on Trump's COVID-19 transition team. And we've been in semi-regular correspondence, but it's been about a month to month and a half since I've talked to him. I'm sure he's real busy. The last person is Dr. David Brenner, who I hope we all get to know sometime soon. He's created this marvelous UV light that actually kills flu and coronaviruses, but does not harm your skin or your eyes. Sad to say, I did pitch these guys as characters, but the production team declined, and maybe they're kicking themselves about it. From there, because I had done so much research about the pandemic potential and coronaviruses and had to be up to date on everything, once I saw those hospitals being in Wuhan, I knew something was sinister was going on. And then as soon as I read the WHO report that came out probably in late February, I released this article. And as I said, what I do outside of the ER is write. And I actually wrote it in late February, but it was released on March 3rd. And if you can think back to the time before this was officially declared a pandemic, but there was a couple of cruise ships that were outside of California, and our President Trump did not want to increase the numbers by 100 and keeping those off base. So that's where we were. Seattle hadn't burgeoned, New York hadn't burgeoned at that point. And so when I released this, I'm just going to read the last part. The COVID-19 pandemic, I called it a pandemic, will be akin to an extremely severe seasonal flu outbreak that will arrive in waves, in which a minority of young and healthy people will be adversely affected, but the elderly and those with pre-existing health conditions will be at real risk, as will the world's healthcare workers. Now, I got a lot of actually questionable emails. This is one of my responses to that person. And it was actually, I got a good few emails from fellow ER physicians and other physicians, none of them in the infectious disease or public health sphere, but saying, hey, they actually called me fearmongerer. They called me a doomsday prepper. They called me stupid. They called me a lot of things. But, once the outbreak occurred in Seattle, and once the outbreak occurred in New York, the emails changed to those of support. I also wrote an article for USA Today, an op-ed called As the Pandemic Rages and We Desperately Need Good Science, Trump Denigrates the True Experts. And this was mostly in support of Dr. Rick Bright, who I was just extremely impressed by his willingness to just put himself on the line, and he dedicated his whole career to pandemics. And in it, I supported him. And I also said the evidence behind hydroxychloroquine is far from complete, and it's actually a dangerous medicine. And I think we all know that those anecdotes or that data and that studies showed that, hydroxychloroquine isn't something that we use for this virus. Before I get into the paper, there's some peer reviewers that have already been mentioned. Paul Pottinger is a director of infectious disease at the University of Washington. And what infectious disease physicians do is they basically treat any infection that can enter a human. So absolutely, they are the specialists in treating coronavirus. And he teaches the fellows who are learning how to be infectious disease physicians at the University of Washington. Dr. Michael Schwartz is a professor of medicine at the University of Washington as well. Kopono has mentioned Carl Kayala, who's a professor of biostatistics. Dr. Thomas Lee is a professor of epidemiology and co-chair of HIPAM here at the University of Hawaii. Dr. Altenberg is a professor of mathematics at the University of Hawaii and member of HIPAM. We've got Kopono, of course. Dr. David DeRoff is chief and director of KKV in Kalihi. Jonathan Dworkin is an internal medicine physician also here in Hawaii. And we've got Dr. Evslin, who we heard from before, and Dr. Tatsunos, who is a critical care physician. So all very prominent physicians who have certified and reviewed this paper.
Netflix, and the woman just went in and
I don't know if somebody's on, if somebody could be muted. Anyway, I'm going to continue on. The objective of this paper was to keep Hawaii afloat from both a public health and economic perspective. We must follow the up-to-date scientific knowledge and research because the availability of vaccinations and any hope of reprieve are still many months away. And Hawaii's current strategy has gone against international, and now since the CDC has released their recommendations, national scientific. I would walk that back, not recommendations, but a preprint paper, their scientific consensus. By one, as Kapono has mentioned, overestimating the efficacy of a one-test system, but also two, underestimating the amount of virus in the United States by using case prevalence instead of true prevalence. So brief history is of the 7 human coronaviruses, of which there are 7 that we know of that can infect humans. There's 4 benign or common cold coronaviruses, of which a third of them are responsible for common colds every year. And then we've got what a lot of people call the pathologic human coronaviruses, SARS-CoV-1, which was the original SARS in 2003, and MERS still bubbles out of Saudi Arabia, but it came out around 2012. 8,000 persons were infected with SARS, a little bit more infected by MERS. But there's some couple key features about this current virus that have made it much more pathogenic. Maybe not pathogenic, but have made it spread much more globally than these prior 2 ones. So this is taken directly from the CDC. It's the current best estimate of how many people are asymptomatic. And that's really one of the keys that have caused this to go silently across the globe and show up in places before you know it. And so 40% of people are asymptomatic, but you would think because they're asymptomatic, they're not really good at giving it to other people, but that's really untrue. They're about 3/4 or 75% as likely or able to give it to other people. And so that's why masks are important, and also erecting fences to keep this virus and testing to keep this virus from coming into borders. Now, when you put these 2 numbers together, plus there's a huge percentage of people who transfer this virus prior to them having symptoms, that's called pre-symptomatic. About half of infections are transferred before there is any hint of symptoms or somebody even knows that they have it. And so these 3 numbers are what gave this virus the capability to spread globally compared to MERS and SARS. With these 2, as long as somebody had symptoms, you were able to put them away either in a hospital or in isolation or quarantine, and they didn't transfer it to anybody else. Now, because of this, you need some containment strategies. And we all know that Hawaii's first containment strategy was a 14-day quarantine. And from a public health standpoint, it's a very good one because this is an illustration of incubation periods. An incubation period is a time that you are exposed to this virus to the time that you actually have symptoms. It's anywhere from, some people can have really, really short incubation periods. Some people can have really long ones, but the common average is around 5 to 6 days, 5.8, somewhere around there. So if you did a quarantine for 14 days, that means the majority of people would have gone through their viral symptoms if they're asymptomatic and not be able to spread it to somebody else. But we all know for an economy like Hawaii's that depends on high volume tourism or that has short stays at certain times of the year, we need to strike a much better balance between public and economic health, because both are detrimental. The answer to this dilemma has, since May of 2020, has been one 72-hour pretest. Now, how reliable is one test? This study was released on June 27th by the Harvard School of Public Health. And the simple answer is, it depends on when the test is taken. Now, on this bottom row here is the days since exposure. So if you're exposed on day 0, this is day 20 since you've been exposed to this virus. And on this y-axis is how much virus is in your body. It's called either viral kinetics or viral load. And I'm going to refer to it as viral load, and just look at this black dot here. In the first 3 days, there's, like a pregnancy test takes weeks to develop, the first 3 days, there's no virus in your system to detect. So these tests, these are our tests here, these horizontal lines. If you take a test in the first 3 days, it's no good. It's not really for the average person, it's not going to detect virus in there. And so this study was released on August 18th. It was in the Annals of Internal Medicine, one of the predominant medical journals here in the United States. And it's called, details what a false negative is. And a false negative is a result that incorrectly says that the coronavirus is absent. So basically, you've got the virus in you, but it's not in high enough levels, or the virus the test didn't work as properly. And so our tests are actually, in the real world situations, according to this study and many others who have been replicated, not very good, even towards the later end of the disease. So I'm going to say, hey, over here, this red star is if you may have encountered this virus. Day 8 is 8 days from when you encountered it. And I'm going to superimpose that viral curve that we just saw on the last slide. And you see it only appears on day 3. So on this y-axis here is the rate of false negativity, and 1 is 100%. So in the first 1, 2, and 3 days, that first 3 days, it's near 100% chance that you're going to get a wrong test. So it's only, remember this one as well, on day 4, it's about 2/3 as of infected, efficacious, about 60%. Really, the test peaks somewhere around day 7, day 8, and they only get to about 80% effective. So that's something important to note. And so this is turned into a global consensus that one test is not enough. And this is a paper out of the New York Times, written by Thomas Pueyo, who's a very talented writer and scientific writer. It was on September 14th, but in it he says, a person will usually test negative just after being infected. This means that people with a negative PCR test 72 hours ago might have caught that virus just before or after the test and are reaching peak contagiousness during travel or after arriving at their destination. So a test at the checkpoint, I'm going to call this an entry test. So a checkpoint test, a lot of global nomenclature is calling this an entry test. So an entry test will allow more opportunity to catch infected people. And another PCR test a few days afterward, with a quarantine in between, will also catch those who got infected just before traveling or during traveling. So this was September 14th by a science journalist. On October 19th from the Wall Street Journal, this was a clip about Dr. Martin Citron, and we'll come back to him at the end of this lecture, where they were talking about the US-UK travel corridor. And so what he says is that, he's insisted in the meetings that travelers isolate for 5 to 7 days upon arrival. And he says that would give a 90% assurance that arriving passengers are COVID-free and won't further spread the coronavirus at their destinations. The emerging travel corridor may one day contribute to a safe, responsible, and healthy global air travel experience. On November 3rd from CNN, they had a story here that said, don't get a false sense of security, with a COVID-19 test. Here's why you can test negative, but still be infected and contagious. And this is out of the Johns Hopkins Bloomberg School of Health. There is no hard and fast rule, but the evidence suggests getting a test before the 3rd day after exposure is not of much use. And this is from a public health specialist at Johns Hopkins. And lastly, here's a study that Capono had referenced. A traveler tested negative for COVID-19 before flight, and this was 48 hours before flight he tested negative. He actually flipped into the positive pre-symptomatic but infectious period, and infected 4 passengers, which turned into 7 passengers. And he only started to have a fever or any sort of symptoms 3 days after he landed. So this is another global consensus that one test is not enough. And so if one test is not enough, we got to do something called surveillance testing, and it's very different from diagnostic testing. Diagnostic testing is if somebody shows up to my emergency department and they have symptoms consistent with coronavirus, I test them, I want to label them with a diagnosis. But people who we're trying to filter through, they don't have a diagnosis. So we're trying to do a surveillance test on them. And what the studies have shown, and this is from the same Harvard researchers that I pointed to earlier, is that you increase frequency of these rapid tests, And that's when you start catching more infections because this curve increases so rapidly. So if you increase the frequency of these rapid tests, which is this low analytic sensitivity test, you're going to catch way more infections than this the highly sensitive PCR tests, which sometimes take days to come back, and we're seeing that those are increasing again. The time from taking the test to results, and they're also more infectious. So we're halfway through the steps. So guys, bear with me. We're still on step 6. These same modelers, this is June 27th, modeled how good is one test at removing infection or surveilling a population of this virus. And so they said on the bottom here, this is how frequently you would test a population. This is how much infection is removed. The brown bar here is our rapid antigen tests. Our pink bar is our really expensive tests. And there's not much difference between our expensive and rapid tests. This hash box here is how many people would isolate. But I think the take home message here is that one test only removes less than 40% of infections. In October, Dr. Daniel Griffin of Columbia University Medical Center, he's a brilliant infectious disease physician who's on a lot of national panels. Him and United Health Group released this COVID-19. Basically, it's really neat. It's a testing strategy simulator where you can put in all the statistics of your school size or college size, how many people are infected, and really see how good is your strategy at removing infections. And so according to this COVID-19 test simulator, they too found that one test, and here's the results, are going to reduce infections. And this is why I inputted our state's statistics. Again, is going to remove around 40% or less than 40% of infections. And so I think we also need to compare ourselves to what other countries are doing, because the United States obviously is not doing so well at the moment. So the countries that have successfully controlled the spread of COVID-19 have instituted much stricter guidelines than Hawaii. And the systems are based on infectious rates of the country of origin, but all of the countries, New Zealand, Australia, Taiwan, Japan, Singapore, Hong Kong, they all put 3 countries into the very high risk category, and the United States is obviously in those 3. So this was also released by a Australian paper, very detailed, very long. It's called it's a 93-page, 18-chapter paper entitled "The Transparent Risk Assessment of Quarantine." And this was published by Australian universities, public health organizations, and also funded and endorsed by the airline Qantas. And you can see here, they risk stratify into these different categories, but the 14-day quarantine category, all 3, especially the United States of the countries I just listed, are in the very high risk. The no quarantine category is very low risk countries like New Zealand, where the community spread is pretty much 0. They have to get an entry test when they land. Now, this paper also went through different options of quarantine and compared them to each other. I would like to say that this is kind of redlining, and they put the red for a reason. Orange, medium, and yellow is careful. So this is I would call the gold standard quarantine, which I mentioned earlier, 14 days. Majority of people have gone through their incubation period. This is where we are now. And what this is the person days of infection after quarantine. So how many people are going to be missed by a test, plus how many days they're infectious for after that test. So it's people times days. So where we are right now, a no quarantine pre-test that's done 3 days prior releases 57 times more person days of infection than a standard 14-day quarantine. What I've been hearing being suggested is that we do an entry test as well, but, and I'll get into why shortly, an entry test plus a pre-test only still lets in 44 times more person days of infection than a standard 14-day quarantine. So that's quite significant, not much difference here. The ones where you start seeing some efficacy is when you start doing quarantines. And I'll get into why in the next step. Actually step 9. So what about the surveillance testing in Hawaii, as Kapono mentioned? Over 90% of what is currently considered a surveillance test should actually be, in international nomenclature, is an entry test or post-arrival test, not a surveillance test. And I'll illustrate why here. Say you're arriving on this day, and this is days since exposure, if you were exposed with this red star here. Say you're arriving on this day, and the traveler opts for a rapid test at the airport of origin, which several of our airlines are doing. You could just do a test at the airport. If it's negative, you get on the plane. So say you get on that plane and you were exposed the day before, that test, as we mentioned, is going to be negative. If you arrive and get a test when you arrive, 6-hour flight from the West Coast, 12-hour flight from the East Coast, you haven't had enough time to get into that viral curve for the test to be of really any use. So that's one reason why an entry test is not a surveillance test. And here's a way that if they arrived on this day, they were exposed again on this day, 4 days prior to their arrival, they got their 72-hour pre-travel test 3 days as they were, as required by the current plan. If they were to get an entry test, if it's a highly sensitive PCR test, it still has, as I mentioned on day 4, roughly a two-thirds or about a 60% false negative rate. Now, if that entry test is a rapid antigen test, which are all the tests that are done on Hawaii Island, then that's a 75% false negative rate. So that entry test, even if somebody was exposed a day prior to arrival, it really is statistically is of little use. So a surveillance test should only be considered one if it's at least 4 days after arrival. And I'll show you why. Say somebody arrives here, they're exposed 3 days before they got here. They had a 48-hour pre-travel test like we saw in New Zealand. The only way you're going to pick that up is when they go through the viral curve is 4 days after arrival. Now let's go through what happens when you take the entry tests out that were all done on Hawaii Island. We look at the core statistics that I would call it clean data or the objective data. First, all of these data are subject to voluntary bias. And what that is there wasn't a whole lot of motive for the visitors, or residents had more of a motive to get their test. And that's why we saw the residents got a surveillance test in much higher numbers than our visitors, but they're all subject to something called voluntary bias, in which they didn't really have a motive if they thought they were, 1, having symptoms, or 2, if they were being risky. All of those people probably would say, nah, I'm going to decline that second test because if I test positive, it's going to ruin my vacation. So let's go through what these numbers actually mean. 3 out of 16 and 616 is 5 in 1,000. And this is from the November 20th numbers that were released by the state. In Maui, 1 of 392 is 3 in 1,000. In Kauai, 5 of 331 is 15 in 1,000. And like I said, we've got to scratch these out because those are, in medicine, something called confounders. They muddy the waters, and if this was submitted to a medical journal, or they would absolutely say throw these out because these are different type of tests than all of these post-arrival 4-day tests. So that's out of 9 of 1339, as Kapono mentioned, or 1 out of 149, and that roughly comes to that number that we keep seeing is about 6 or 7 in 1,000. And if you multiply that by 3,000 visitors or returning residents, that's theoretically 2,100 total that have arrived here undetected, infected, but as Dr. Esvelin has said, undetected. And so with the continued surge on the mainland, which we're seeing a surge on a surge, actually, as it's been alluded to, this is only going to get worse. And what does this look like on Kauai? And Dr. Berman can get a little bit more into this, is that over here, Kauai had really no community spread and very low infections for, months. And then once October 15th rolled around, the infections really started to increase. And I think another important note, and probably the most important note, and when the calculations went off, was that think of this as Kapono mentioned, an iceberg. That the detected cases are really just the tip of the iceberg. The undetected cases are much more profound, and they are profound for several reasons. So this was the tip of the iceberg that our state used to calculate their 1 in 1,000 number. This group might be somebody who's POWSI symptomatic. I'm sorry, that's a fancy term, but it just basically means, they have so mild symptoms that it's only when they're asked, they're like, oh yeah, I might have a headache, or, a little scratchy throat, or they're unable to get tested, can't afford a test, don't believe in this virus. As unfortunately, there are some folks out there that are like that. And then you've got, as I mentioned, that asymptomatic group. So in total, this case prevalence should be multiplied by at least 3 to 10 times. Again, our HIPAM, our data group here, multiplies it by 7 times to get the correct number. So when you combine an overestimation of testing accuracy, because it's been used, 80% has been used multiple times by at least double, and an underestimation of the true prevalence, as we just saw, it's only the tip of the iceberg. You got to think about everything that's floating underneath, of at least 3 to 10 times. And I'm just going to take the number 3 here, the lower number. You get an infectious traveler rate that is at minimum 6 times higher than our state predicted. And I think this illustration really kind of illustrates the porousness of a one-test system. Say you arrive here on this day, day 6, and you're exposed to the virus on day 0. If you get a 72-hour pre-travel test, there's pretty much very, very little chance that that test is going to pick you up and you're going to arrive right in the middle of your infectious curve. You may have symptoms, but if you're of younger age, or you're in the large group of asymptomatic or POWSI symptomatic people, you're going to be shedding a lot of virus both during travel and when you arrive. Now, we have to touch on masks. It's absolutely crucial that everybody does wear masks, and that's one of the reasons why, because we've had so many infections arrive to our state, as according to the state's own data, that our cases have not exploded quite just yet. And so this is from also the University of Washington, where they proposed, this is Hawaii's, and this was taken back November 16th. I'm just using the same screenshot, but this is Hawaii's infectious rate if we continued with just an 80% mask use, and this is if we went to 95%. So very, very stark difference. So we need to, as usual, as everybody has always said, is wear your masks. Just because so many people are asymptomatic, you don't know that you have it. Now, lastly, this paper is a preprint paper, as Dr. Edgelin has alluded to, released on November 24th, coincidentally the same day as our paper. We had no idea it was coming out, but this is from the CDC. So I've gone through a lot of the international scientific consensus, and now let's talk about our national scientific consensus. And this is reducing travel related to SARS-CoV-2 with layered mitigation measures, includes symptom monitoring, quarantine, and testing. And notice one of the authors here is one that I cited around step 5 or step 6 is Dr. Martin Citron. Now, this is all doctors from the Centers for Disease Control, and it's not a position paper, but it's their preliminary scientific consensus from some of the most robust doctors at the CDC. And I apologize that I'm going to be reading a lot of this, but I think it's very important. Control of SARS-CoV-2 is contingent upon multiple layered mitigation measures. Reducing the risk of transmission associated with travel is critical to reducing the impact related to importations on local health and healthcare systems. This is important when transmission at the destination is low, such as it is in Kauai, Lanai, actually all of our islands, and an introduction could spur additional outbreaks. But when transmission is already high and healthcare systems may be strained, it's also going to be useful. Now, reducing risks associated with air travel could pave the way to air industry recovery, as well as offer relief to national or our own state economy and reduce social distress. Now, this is directly from the CDC and kind of sums up exactly the dilemma and economic dilemma we are in. Now, there's been a lot of talk about moving the pretest back to 4 days, and this paper also addressed moving the pretest. And back to 4 days. And I think I applaud our state for thinking outside of the box, but when you really look at the viral kinetics and viral dynamics of this virus, this is what the CDC says. On the other hand, testing more than 3 days before travel provides little benefit beyond what symptom monitoring can provide. Now, what that means is moving it before 3 days, it's actually no more of better use than just asking people if they have fevers or screening if they have fevers or if they have any symptoms. So that's from the CDC. And so I think moving a test before 3 days is not of robust scientific or medical guidance, but I understand the recommendations as our PCR tests are taking a little bit longer to come back and our travelers aren't being able to get on the plane, but it's going to render our pretest fairly not as useful or fairly useless. So their final recommendation, a shorter quarantine of 7 days combined with symptom monitoring and test on day 3 to 4 of arrival is also effective at reducing introduction risk and is less burdensome, which may improve adherence. So notice it's a quarantine of 7 days and a test on 3 to 4. So you have enough time to get that test back at 7 days and included 7 days of symptom monitoring. Now we're in this a limbo, and I've mentioned the word balance, like economic balance and public health balance. And all of these options that we're currently entertaining, again, this is the gold standard. This is 57 times more than the gold standard. This is the other one where entry test only, which they're currently doing on Hawaii Island, releases 44 times more infectious person days. I think we're still redlining too high, and we've seen that by, Lanai's had to shut down, and Dr. Berryman will talk about the numbers she's seeing in Kauai. Just a moment on the economics of this virus. We all know that the public health and economic health are intertwined. This was a slide by Dr. Brubaker where he said, basically look at the end here, as our cases skyrocketed in August, our economic activity also went down. So as our cases increase, you can see in Lanai, I'm sure their economic activity, when they had to shut down, went starkly to zero. And Mayor Kawakami has seen some of those actual results as well. And I'll let the economic professors talk about the economics. But I do realize that you've got to weigh both sides of the coin. So just some couple conclusions. When we're now 4 to 6 months to go before at least 2/3 of our population need to get vaccinated to get some semblance of herd immunity, we need to bring that balance back. We need to recognize that we're seeing more cases with a one-test system than we predicted. And those were predictably unpredictable according to our calculations. And so as the Department of Health has previously recommended, we also recommend reinstating some length of quarantine for visitors and returning residents that culminates with a second test as deemed accessible by all economic and public health parties. And just in some closing comments to the business and economic sector, I know it's a terribly bitter pill that one test still seems to be way more porous than we think. But I've been on CNN time and time again from mostly that USA Today article I wrote and mentioned earlier, saying, as soon as you turn your back on science, that's when things go the wrong direction. So to get us out of this dirty puddle, as Kapono had mentioned, we need to use science as guidance. And to our state leadership, we implore you to come back together with the Department of Health and find some balance. And to the people of Hawaii, hang in there. I know it's extremely confusing and also terrible from both angles. But when I think about what I've seen both in the emergency department in August, where in the span of 24 hours, I had to put 3 different members of the same family on a ventilator machine, and also walk through the halls of the worst nursing home outbreak our state has seen at the Yukio Kutsu Nursing Home Center, where we had 29 people previously uninfected down to 10, and luckily it was stopped. The risks are really too high. If you give just this virus a little bit of breath, it's gonna it's really going to take hold. And it obeys something called the Pareto principle, which is a economic principle, and that 20% of usually a business's clients or represent 80% of the sales. And this virus does the same thing. Most people don't transfer it to anybody else, but 20% of the people transfer it to a lot of people. And I'd like to just close with, this is a photo taken somewhere around day 4 of that voyage from San Diego back to Honolulu, just with a mo'olelo that the Polynesian Voyaging Society, I think, really kind of distills the wisdom of our voyagers, and that he wa'a he moku he wa'a. Canoe is an island, and an island is a canoe. And this photo really illustrates that everybody on the canoe and everybody on our island plays a role in this virus. And the more that we harness the values of aloha, kuleana, and responsibility to ourselves and our neighbors, that we can get through this. So I've been talking long enough, and I'd like to hand it over to Dr. Berriman. Thank you so much.
Thank you. I'd like to do a time check with Mel and Charlie. I'm not sure how long we have to go. Shall we turn it over to questions here? Shall I say a few brief comments?
Yeah, Dr. Berriman, if you can say a few brief comments, and then I know we have a bunch of people on the Zoom that will open up in a few minutes. But yeah, if you could just touch basis on the Kauai numbers and what Kauai did.
Okay.
Thank you.
Okay. First, I want to say a big thank you to my 3 colleagues who have spoken in advance. You 3 have done an enormous amount of work really plowing into the data in a way that I have not been able to get into it as deeply. And it's really an honor and a pleasure to have you folks here on Kauai and so interested in these problems. I want to kind of bring the discussion a little bit out of the realm of mathematics and models and predictions and really ground it in what we've seen in Kauai, because we can anticipate what the impact of things might be and talk about the effectiveness of various kinds of screening. And that helps us plan and should help us design our programs and our approaches. And then when we implement something, we have an opportunity to say, how did that actually play out in the real world? And I think Kauai is a very good way for us to see how the single pretest program is playing out in our state. And Kauai is only a microcosm of the state. But as one of the graphs showed, Kauai has had very little disease over the last many months. So before October 15th, we had 61 cases of COVID-19 in Kauai over 7.5 months. Between October 15th and today, we've had 70 cases of COVID-19. So we've more than doubled our cumulative number of cases in just the last 6 weeks. So clearly something has changed. And what changed on October 15th was lifting the restrictions on travel to allow travelers to come to our island, our county, if they had 1 test before they traveled, then they didn't need to be in quarantine at all. And of those 70 cases that we've seen, 57 of those have been travelers themselves, and another 5 have been people who had close contact with those travelers. And of those travelers, I think it's important especially for our residents to know that 27 of those 57 travelers were residents coming back home. So this isn't just a visitor and tourism issue. This is a resident and a visitor issue. There are 30 of the cases were in visitors, so slightly more among visitors, but pretty close to half and half. And of those travelers, a full 35 of the 57 had a pretest before they had a test before they traveled and got their result, and that result was negative. And so they traveled, they were fully in compliance with the screening program. But after they got here, either because they thought it was the responsible thing to do or because they weren't feeling well, they got a test when they were on our island and then became cases. In addition, again, one of you referred to this before, 16 of the cases here on Kauai have been people who also got their test before they traveled, but didn't have their results before they got on the plane. And after they arrived here, those tests were positive. And that's a group that is very concerning because they actually flew while they were infectious. And so they present a risk not only to people here in their activities on Kauai, but to all of the people that they traveled with. And it was in our county press release yesterday that unfortunately we had 2 residents returning here to Kauai who received their positive test before they traveled and were advised not to get on the plane and chose to do so anyway. So that clearly is disappointing behavior. So the rise in cases that we're seeing on Kauai is very clearly linked primarily to travel. And the additional piece that's concerning is, again, still a small number, but we've had 8 cases now that are what we call community transmission or community acquired disease. And we had not seen that since June or since late June and early July on Kauai. And what that means is these are people who have had a confirmed positive test for COVID-19, but we can't, after a full investigation, we can't tell where they got it from. So they don't have any connection to a traveler. So that tells us that travel is bringing disease into our island. That disease is spreading, most likely among asymptomatic people, and then it's popping up in our residents in ways that we can't connect all the dots. And that's when there's the opportunity for this disease to really take hold in our community and spread like wildfire in the way that it has and is in many, many communities in the rest of the country, in the mainland, and all over the world. And Kauai's recent move to put a moratorium on our participation in the Safe Travels program was, as Dr. Evslin said in the beginning, I think it really demonstrates courageous leadership by our mayor and by the governor in approving that, because it takes courage to step out in front and take proactive measures to prevent a crisis rather than waiting until you see the crisis very, very close to your shores, if you're thinking of a tsunami metaphor, and take action when the wave is already crashing or the waters are already rising. So there've been characterizations that that Kauai is afraid of COVID-19 or that we don't have the capacity to handle small numbers of cases. And it's not really about the absolute numbers right now. It's about the trends, and it's about looking at what's happened here in the last 6 weeks, what's happening on the mainland, and where we've seen the leaky places, if you will, in the Safe Travels program. If I can just say one sort of part of what we're thinking about in this moratorium on safe travels, we also know that this coming month is a continued holiday month, continued desire for social gatherings, for celebrations, continued travel for holidays of returning children from college and things like that. And by tamping down the travel arrivals on Kauai, we will have an opportunity to really maintain that community spread that we're getting indications is starting to rise. It will also allow our students to go back to school, to continue to go to school in a relatively safe environment, because we will be able to control that community spread. And it will allow our local businesses to cater to local residents, again, in an environment in which we can all feel relatively safe, as we have here on Kauai for many months. And it further will allow us to prepare for vaccines, some of which may be arriving before the end of December, and certainly more after the beginning of the year. And it also gives us an opportunity to take a step back, look at the Safe Travels program, and think about how can it be made stronger? How can we welcome travelers and visitors, as well as our residents, to travel? Because we know that's integral not only to the tourism industry, but to all of our well-being and connectedness to the people that we know and care about on the mainland. So I think it's a measured and appropriate response at this time, and I appreciate all of the work that's gone into the analysis of the data that supports these decisions as well. Thank you.
Thank you, Dr. Behrman, and thank you all to our panelists of doctors. You guys, thank you for the information. We do have about 11 media people on the Zoom. I believe you have a little raise your hand button on the screen somewhere. If you could hit raise your hand, and then I'll go ahead and we'll take some questions from the media. Let's see. Hang on here. I can put them all on the screen. Maybe I'll do that just because. If any, are there any questions from the media? I did have a couple of. Oh. Oh, okay. Here we go.
Oh, hi. This is Ashley from HPR. Thanks for doing this. I think my question was kind of, we've heard a lot of these numbers. Is there any, I guess, acceptable percentage, I guess, of acceptable numbers that you guys would feel comfortable with slipping through? Like, at what point is the number you're wanting to hit? Obviously, we don't want to hit 0, but that doesn't seem like that's an attainable goal right now. So is there a percentage that make you guys feel comfortable at least, or more comfortable that we could aim towards?
I can take a stab at that, Ashley. Hi, it's nice to hear from you.
Thanks.
Yeah, I think I've had an opportunity to say to you, and I know to others, that this disease is really about the trends more than it is about any single number at any single point in time. So, if there were 15 cases today on Kauai, and yesterday there had been 25, and the day before that 35, then 15 would feel like a good number. But if there have been no cases for the last several weeks, and then suddenly there are 15, and that continues to escalate, then that's concerning. So I think that what's concerning, and I have said alarming right now, is the rapid rise that we've seen in cases here on Kauai over the last 6 weeks, and coupled with the very rapid rise in very high numbers that we're seeing on the mainland. So to me, acceptable would be seeing a clear downward trend and sense that disease on the mainland is contained, so that we know that people traveling to our state are not coming from areas where they're very much more likely to have been infected. And then similarly here, seeing stability in our numbers or decreasing, but even low-level stability would be acceptable. But it's the rapid rate of rise that we know only continues to escalate. And we've seen that over and over and over again in many communities. So I would really encourage people to look at the direction of change more than a single absolute number. And I'd be happy for others to comment.
Yeah, actually, I just would also take a stab at that question in that, 1 in 1,000 sounds, if you're working, one of the 250,000 of us that work in the visitor industry sounds, pretty low, but the numbers are closer to, 1 in 100. And I think that's a risk that, would be different than, for everybody, but especially different for somebody who works in the visitor industry. Also, our families as well. This is not just visitors. This is returning residents coming home from college. Both are equally needed to take the appropriate precautions.
I had a quick follow-up to that, or a little bit, it's a little different. How comfortable do you guys feel about the contact tracing efforts that have been done since the travel has reopened? Do you feel like those efforts have been effective, or have they been able to field a lot of the make those connections and contact those who have been infected, especially tourists? I've heard some concern about tourists maybe have, or travelers in general, who have just like returning residents who have tested negative in coming into Honolulu, and then proceeded to maybe island hop between Kauai or Maui and tested negative within that time, and then had some issues. Do you guys feel confident about the contact tracing efforts right now?
So that feels like a Department of Health.
Yeah, that might be more them.
I have two perspectives on that. So the statewide perspective, I'm a little bit less well able to speak to, but as you know, and it's been much in the news, we have much greater contact tracing capacity now than we did in August at the height of our cases in the state. And even though cases are still higher in the rest of the state than they are in Kauai, we are not approaching where we were in August. And we have a robust, the Department of Health has a robust case investigation and contact tracing capacity in terms of staffing, and also has worked a lot to prioritize and focus those resources to more thoroughly investigate the cases that pose risk of exposing people who are in high risk situations, either because of their age or underlying health conditions, or because they're in congregate situations. That said, I think it's also been in the news that a fair number of the cases that are reported to us come with either with an incorrect phone number or no phone number at all. And so there is a percentage of the cases that the Department of Health is essentially never able to contact. So I think that we're doing a better job than we were able to do in August, and that issue of being unable to contact people remains challenging. Speaking to Kauai, we are a small community. People know a lot of people. Even if we don't have the right phone number, we often are able to figure out who people are and where they are and find our way to them. So we have been able to reach and do a contact investigation for every single one of our cases, usually within 24 hours. There have been a couple of exceptions to that, and do very thorough contact investigations and contact identification. Of course, people are not always 100% truthful to us. So I'm not saying that we haven't missed anything, but I feel confident with the work that we've been doing here on Kauai that it has been of extremely high caliber, and we have in no way reached a maximum capacity for our ability to do case investigation and contact tracing.
That's all for me.
Thank you very much, Ashley. Appreciate you jumping on. Is there anyone else in the media community that had a question? I still see a few of you on Zoom. I did have a question, and it came from one of the viewers, and I'm not sure which one can answer, but Kauai just had 2 returning residents come back from the mainland, and apparently was informed of their positive results prior to departing. And the big question is, how in the world are they allowed to get on a plane and fly with a positive test? And I think it's been answered many times on Facebook through various people saying that it's not illegal to get on a plane, or there's no rule, and really no one knows. You're on your own until you get to Kauai. Does anyone know, maybe you, Dr. Berman, or any information on how that occurred and what happened?
Well, I don't know the particulars, but the Centers for Disease Control operates quarantine stations at major airports, including Honolulu, San Francisco, Seattle, I believe. I know San Francisco and Honolulu. And they are the ones who are tasked with monitoring or limiting or forbidding to board people who pose a public health threat to other travelers, including COVID-19. So our understanding is that in this case, the Centers for Disease Control Quarantine Center in San Francisco did advise these individuals not to travel, and their understanding was that the individuals understood and would comply with that. What the quarantine center did not do, which they do have the power to do, is to go through a process to put these people on an official list called the Do Not Board list, where when they attempt to check into their flight, their reservations are flagged and they are not allowed to board the plane. And we have had to take that precaution with individuals who were identified here on Kauai and were threatening to leave when they were not supposed to leave. So I think the timing was such in this recent episode that was not possible, but I wasn't part of that decision making, so I don't know. But there is actually a way to make it illegal. It requires jumping through some hoops with the Centers for Disease Control.
Thank you, Dr. Berman. The other question was regarding, and Kapono, Dr. Kapono, probably you, because you mentioned it earlier. Prior to today, we had been the state informed us, or the state's reporting of the numbers of positive cases that were since October 15th was in about the 40 to 50 range And today, for the first time, we heard the governor mention in his conference with, or his interview with the Star Advertiser, that in fact, it's over 300 cases that has arrived in Hawaii and found out that they were positive after arrival. And we know that Kauai's numbers, thank you for, Dr. Behrman, thank you for providing the Kauai numbers. So that changes kind of the argument, because there's a whole lot more out there that makes it through with the Safe Travel program, that finds out after their arrival that they're positive. And again, from the governor's interview today, it's over 300. That is not being reported. And I think, Dr. Behrman, maybe you can help as well. Our cases, if it originates from another state, gets counted in that state, but not in Hawaii. But for Kauai, isn't it true that Kauai counts all the active cases and reports the active cases, even if the infection was passed on the mainland?
Yeah, so statewide, any Hawaii resident who's diagnosed anywhere in the country, as long as that's reported to us, that gets included. And if you're used to looking at the state data on the website, there's a category of Hawaii residents diagnosed elsewhere. They're not assigned by county, but they are counted into the total state cases. And anyone who's diagnosed in our state is counted in our state statistics, even if they are a resident somewhere else, although we also notify the place that they came from of their positive result. The group that is not routinely counted in the state numbers is residents of other states who get a test in that state and then come here and are here when that positive test result is obtained. And the reason that's not reported at the statewide is at the state level is that we don't have a systematic way of getting that information. But here on Kauai, again, because we're small and we get a lot of information through informal paths, we began to hear about these cases early on, and we felt strongly that it was important to include those in our totals because our numbers are small, and 16 out of 70 is a significant portion of the cases here. So we are reporting those routinely on Kauai. And the other counties are tracking that. I don't know what they're doing in terms of reporting it publicly. And I actually can't speak to the figure of 300 and some of those cases statewide. I hadn't heard that put together. And I don't want to either confirm or refute that. I'm just not 100% sure where all those numbers came from.
Yeah, he mentioned it today, and in fact, the reporter had to go back and ask him to clarify, because I think we all were kind of surprised to hear that number, but he did say he confirmed it with the Department of Health. So that's what was said this morning at the 10 o'clock interview, but we'll definitely follow up with that.
Another video conference, so I'm
yeah, thank you.
Sure.
Charlie has a question.
This question is for any of our panelists today. It comes from one of the viewers. How many critical care experts are there many beds on each island? Anybody wish to try to answer that?
Yeah, go ahead, Kapono. After I'll just add this, is that I've worked on both Kauai and Molokai, and on Molokai, there are no critical care experts that reside there, just the emergency physician. And then at KVMH, there is no overnight critical care physician, as much as I know, as well as Samuel Mahailona. And then on some of the smaller hospitals on the Hawaii island, there are no critical care experts as well. And that's really a rural and critical access medicine, where they do mostly telemedicine. So that puts the smaller neighbor islands at risk when it comes to critical physicians. Sorry, Kapono, go ahead.
Oh, that's okay. I was doing elementary school, raised my hand. I know on Kauai, I only know of one pulmonary critical care physician on the island. And I'm not sure how much he gets involved in routine, ICU care in the hospital, but that's what's available on the island as far as I know it. So I think most of the COVID cases would be managed by hospitalists who are probably internal medicine trained, or maybe family medicine trained like me. And we have, our infectious disease specialist, Dr. Hillsland, who's, I believe, helps out a lot, but she's not pulmonary critical care. So I think I think the viewer that asked the question makes a good point that, we don't have a lot of critical care support. And on the neighbor islands, we tend to transfer a lot of those patients to Oahu for care, sometimes even to Maui. But yeah, we don't have a lot of resources there, and we don't have a lot of experience. But I can say I'm really impressed by our infectious disease specialist and how much she's on top of all the literature as far as treatment and treatment protocols. So I think that Kauai is sort of as prepared as we can be, but it's sort of how prepared can you be until you get into practice and really deal with the disease that is relatively new for us here.
Thank you. One more question. Again, it's a Dr. Behrman question. The percentage of visitors and returning residents that are taking the post-arrival test, the voluntary post-arrival test here on Kauai, any idea? I know the first estimates were like 20% for residents and 2% for visitors. Is that pretty much still the same?
Yeah, those are the percentages of people being tested at the county's 72-hour or more post-testing program. So that does not include people who were tested as part of the surveillance study that was referenced earlier. And I have to say, I have not repeated that calculation recently, but I believe that ballpark figure remains about the same.
And I just wanted to jump on that. So I was talking fast, but the last I knew was that positive or 5 positive returning residents out of 750 tested.
5 out of 750.
That's part of the county.
Got it.
Counties, I believe that's right, Capono. It may be it may be 6 or so now, but yeah.
Well,
Any more go ahead, Dr. Everson.
I was just going to talk a little bit about capacity to take care of surging illness. One, as I mentioned before, our neighbor islands are actually surprisingly sophisticated, but we don't have extra capacity. For instance, every flu season, we're right at the edge of not having any beds left. So if you added COVID to a flu season, that can be a dramatic change. Not that you can't uptick the hospital in a way by changing different kinds of beds into beds that can take care of critically ill people, but it would still be an issue. But a bigger issue or another issue is just the general staffing. One thing is critical care physicians, but 2 is just your staffing in general. You start having COVID going through nursing units, and suddenly you have no nurses that are used to taking care of critically ill patients either. So on these small hospital systems, and they've seen this in South Dakota and North Dakota and everywhere that has similar situations to us, it is so easy to overwhelm a small hospital system. And then you add the fact we have to fly our people. We can't put them in an ambulance and drive them away and so on. That is a major concern on a neighbor island, basically, is how do you deal with the surge? That is always
and what is the number of ICU beds on Kauai? We keep hearing the number 9. Is that the number for island-wide between KVMH and Wilcox? Is that the true number?
It used to be called 9 to 11. Basically, you could stretch a little bit. I think that's 15 ventilators. Those are the numbers that I've heard, and they've been bandied about. Capono, that's still the numbers that you're using?
Yeah, that's what I know. I think when I came on your show, I think the 9 to 11 is because the last time I went by the ICU at KVMH, usually it's not full. So one of the rooms might be just like full of maybe the extra ventilators or equipment, or that's not like really a readily workable bed, but it could be made into an ICU bed in theory if everything was moved out. So I suspect that maybe Wilcox has another situation like that, where there could be 11, but maybe 9 is really, what is used on a regular basis.
Yeah, but then again, the staffing, as Dr. Evslin talked about, the critical care is a whole specialty in and of itself, where Charlie and I were talking about our experiences in hospitals at various times, and knowing that you have some very high-level nursing personnel that are trained specifically for the condition that you're in the hospital for, and then you have, general nursing personnel. So COVID is, I mean, it's tough to treat a COVID patient if without trained COVID medical personnel. Is that correct?
Well, I would like to just do a little bit of a shout out to the hospital because Wilcox has managed all of the hospitalized patients that we've had. And the first one was relatively early on in the pandemic and was very, very ill and was transferred to Oahu. But since October 15th, again, we've seen, I have to confess, I don't remember if it's 4 or 5 additional, I believe 5 additional hospitalizations. And those have all been managed very competently by the staff at Wilcox Hospital, sometimes as many as 3 at a time in intensive care level beds. So, kind of small but mighty is the way we roll on Kauai. And I really think that our healthcare partners on the inpatient side are doing a marvelous job. And as others say, that doesn't mean that we have limitless depth. All of our resources are finite. In the health department as well as in the healthcare sector. And I would add that, law enforcement has been burdened by, they've been taking the primary responsibility with the National Guard for enforcing quarantine, the travel quarantine. And unfortunately, they've had to be involved with the cases that we've had recently of people who were not willing to follow the direction of the health department, where we had to actually go down the path of involving law enforcement. So there are many ways in which the excess cases can tax our local resources here on Kauai.
Perfect. Okay, I'm going to bring everybody back on the screen and give everyone one more opportunity to raise their hand. If you're on here, I know we got a bunch of media people on here still yet. Any other questions for our panel? Okay, dokie. All right. Well, any closing comments by any of you? Again, we appreciate you guys so much for taking the time. I know we went a lot longer than we thought, but I think the information based on the comments were very, very good. So any closing comments by any one of you? The hint is we're going into the holiday season right now. That's a clue for the doctors.
I was going to let I feel like this is primarily my colleague's show, so maybe I'll say what I say at the end of everything, but emphasize it in terms of the holidays. I was chatting with people in the Emergency Operations Center today with our assistant fire chief and our assistant, one of the police chiefs who's here, and the emergency management folks about what the Thanksgiving holiday weekend looked like here on Kauai. And what I heard from everyone, because I don't get out, is that it was very quiet and uncharacteristically quiet, and that there were not the kinds of large gatherings that we had been concerned that there might be. So that actually, I think, is a reason to thank our residents in our community, and tells me that people are taking apart the advice that's being given. And it also, is a reminder that we are headed into another month of holiday season, and times when we should really not be gathering in the large ways that we're accustomed to gathering and that we enjoy gathering. So, wearing masks, as was pointed out, is the number one thing to do to protect yourself and those around you. Washing your hands, keeping your distance. And if you're gathering with people from outside your household, do so in small groups, do it distanced, do it outside if at all possible, and wear your masks when you're not eating and drinking. Thanks.
Just got a late question. If anyone wants to, we don't have to spend much time on it because it's a huge topic that probably warrants a show in itself. But vaccine, the possibility of the vaccine getting here, what's the time frame and what's the likely impact? And you can take turns if you want.
Sure. You want me to do like 1 minute?
So, yeah, real quick.
like we will get, so vaccine is going to come initially as a trickle and ultimately will be a flow. And how long it will take to get from the trickle to the flow, we don't know. But the timeframes that are out there, and I don't have any particular insider information, is that that trickle may begin before the end of December. And that would be a small amount targeted for frontline healthcare providers, first responders, and some of our very highest risk residents. And then the flow where more and more people can get it in lower and lower priority groups is likely not to really get flowing until the sort of April timeframe. But as I've said before, my crystal ball is no clearer than anyone else's. But we clearly have a number of vaccines in the pipeline. The one that's likely to come out first is the one that poses the most challenges in terms of having to be kept extremely cold, which especially in our tropical climate and with vaccine having to be transported among the islands is particularly challenging. And vaccines will be an added layer of protection for us, but they will not be a flip the switch and now we don't have to be careful anymore, initiative. They will be something that helps. And as more and more people are vaccinated, we'll be able to relax some of those other restrictions gradually, but it's not going to be a sudden on and off.
Beautiful. All righty. Thank you again. Anyone else before we start to wrap this up? I know it's late. No? Okay. Thank you.
Well, I'll take your hint and just say thank you to you guys for giving us this venue to share information, and thank you to all the media participants and my colleagues for joining in. And so I want to also say mahalo to our mayor, for being willing to consider these concerns and make the courageous steps that he did. And now it looks like the governor as well, coming around, about these concerns. So, and the last thing I wanted to say mahalo for is just to all of our community. We are just so lucky to live where we live and live generally in a community where people are willing to put in the effort to take care of each other in a situation like this. I particularly feel lucky to live Kauai right now. And, I think overall, we're all lucky to live in this island where we have a natural protection, by our islands.
I'll take you up too, Mel, just briefly. I also want to say thank you, particularly to all the viewers, because this is not an easy issue. To have a difference in scientific opinions is the way science moves. So because the state has done different calculations and has different answers that they're getting from their calculations, this is what science and life is all about. And we're trying to offer, there's another side to this, a side that's quite worrisome, and we'd like people to understand that side of it. And I thank Mel and Charlie for making this platform possible, that people can come and have a discussion like this and put it out to the world. So we may have sounded critical of other people's thoughts on the process. We know it's not easy, the economic side to it and the medical side and the balance between the two. But I did think we all felt it was important to put out this reason that the scientific reasoning needed to be perhaps balanced in another way. So I thank all the people that have stayed to the end of the show and listened to us and are thinking also along the same lines. And again, so lucky to live on Kauai and have people like Dr. Berriman and all taking care of us and all of our front line. Thank you.
Thank you, Doc. Mr. O'Carroll, Dr. O'Carroll.
All right. I just want to say real brief, thank you all for being here. Thank you for all the visitors for watching us and staying to the end. And our whole goal was just to present the most up-to-date international and national scientific consensus and where Hawaii can lead itself out of this pandemic. Because as Dr. Eslin has said, and everybody here, it's not an easy decision, but as long as we use the most up-to-date science and guidance, I think we can get out of it. So thank you.
All right, thank you, thank you. Charles Iona.
Okay, well, there you go. Well, first I'd like to, as always, thank our guests, and I thank you so much for joining us. It's truly an honor just to, kick back tonight and I shouldn't use the word kick back, but just lay back and listen to all the important information that came out. To our viewers out there, again, Mel and I, we're just two simple guys that just love to bring out the information. And, whatever you folks learned tonight or whatever you can use, perfect. And if there's something that just didn't appeal to you, then we move on. But we'll continue to educate and inform. There's always going to be differences. There's no doubt about that, especially with the science as the way it is. I know I've read a lot of comments today that was very critical of our mayor. And then there are a lot of comments that was in support of the mayor. I look at it as, like a forest fire. We can cut a fire break hoping that will stop the advancement of that fire. But if that fire break is not done correctly, it'll jump the line and it'll spread really fast. And we won't have time to outrun it. There is no way. There is no way. And again, if you look at the number of victims in this world today, just from this virus alone, it is mind-boggling. I never thought in my lifetime I would see something like that. So I'm just hoping and praying that things can be brought under control relatively quickly, but in all honesty, it's gonna take some time. And I hope someone had posed the question, what can we do? Maybe you can write to the governor, write to the lieutenant governor, and just say, give them your manao, your 2 cents, and just let them know that, is there something that we can do to just try a different approach? Because everything that's been presented tonight, ladies and gentlemen, that it just comes from pure science, and these doctors are giving up their time to share that information with all of you. So I'd just like to say a big mahalo to all of them as well. Mel?
Thank you, Charlie. All right. Thank you, Dr. Berriman, Dr. Chong Hansen, Dr. O'Carroll, Dr. Eslin. Amazing information today. We just appreciate you guys so much for spending this very long period of time sharing the data, sharing the science with our viewers. We had a lot of new viewers on tonight, so this will be, you can watch this again on the YouTube channel, my YouTube channel, Mel Raposo. You can watch this, you can record it, do whatever you want. Share this information if possible, please, because I think it's important that everybody gets this information so they can understand what's going on. Also want to thank Huike. We had this brilliant idea that we're gonna do the studio thing while we were at Huike, but unfortunately we couldn't get the connection between their high-tech $100,000 cameras to my laptop. So, but the lighting is here. That's why I got blue hair. We're in a studio. We're having fun. And I want to thank Huike for making this place, Jay Robertson and his crew for making this place available for us. Next time we do this, I'll make sure we have the right equipment. And then to the media for agreeing to come on and hanging out with us for about an hour and a half, hour 40 minutes. Thank you so much. We appreciate when the media puts out the factual data and informs and educates the public, which is what we really try to do. So again, take care, you folks. Oh, God bless you guys. As the holiday season is upon us, please, people, don't get into huge gatherings. Wear your mask, wash your hands. We got Christmas and we got the New Year's coming up. This could be really bad or this could be very good. Please, let's be safe. Take care, you guys. God bless. We'll talk to you soon. Aloha.